Great. So we'll resume. So you are able to look at the increased air resistance both in the scalars as well as in the loops. So next we come to the pressure volume loops. So volume is on the y-axis and the pressure is on the x-axis. Inspiratory curve is usually upwards and expiratory curve is usually downwards. And I'll be showing the lower inflection point and the upper inflection point in the next slide in a bit of detail. So this is how the curve looks like when you give a breath. This is the inspiration, this is the peep, this is the volume, and this is the pressure. So this is the peep. Initially, you overcome the air resistance. This is the optimal compliance over the lower inflection point. And then as we reach the higher end, there is angular distension. So there are newer ventilators which say they can actually calculate the lower inflection point. But remember, there is a space in which the compliance is very good. That is, we need to identify in all of the patients. So this is the pressure volume loop, the inspiration and the expiration. Is this clockwise or counterclockwise? Anyone?
This
is counterclockwise. So this is a mechanical ventilation breath. Suppose we have a spontaneous breath. How does it look like? So spontaneous breath is clockwise, whereas the controlled breath is counterclockwise. And if you give a peep, it will slightly move to this side. This is assisted breath. So initially, it will have a clockwise thing like the spontaneous breath and then move in a counterclockwise direction. So I'll be showing you this in detail. This is the mandatory breath, the mechanical ventilator breath. The inspiration is counterclockwise and then the expiration is there. And if we give a peep, it is shifted to the right. Whereas this is a spontaneous breath, clockwise. And if you give an assisted breath, initially clockwise like a spontaneous breath and then counterclockwise. So remember this part. This is what I was talking about. If you give a peep, the whole thing moves to the right.
Yes, sir.
This is how peep looks like. You should all be aware, if you see one thing in the scalars, you should confirm that by the loops. Not only peep, but if you have increased resistance, decreased compliance, air leak, air trapping, everything. So we could see the inadequate inspiratory flow initially, and this is how you identify it. This is because of active inspiration. This is the inspiratory part. There is scalloping in the inspiratory part. The patient is trying to actively inspire, and there is inadequate flow. Remember, the air leak is on the volume axis. It does not reach the baseline. So put together, you can identify with the wherever volume is involved. So volume times scalar. This one. Volume times scalar. This is the loop. Which loop is this? Anyone? Yeah? Flow volume. And this is the pressure volume. So wherever volume is on the axis, it does not reach the baseline. So you have to see all of this to identify that there is the air leak. There is someone we wanted to enter the room, please. So increase air resistance. Your shape of the loop broadens and the slope decreases. Whereas in decreased compliance, the whole loop is shifted downwards. So what it happens? With the same pressure, you can only generate a lower volume. That we mean by shifting of the loop downwards. So suppose we have a volume controlled ventilation, what will happen? This is a volume controlled ventilation. Volume is set. The pressures will rise in case of decreased compliance. So compliance is decreased, the pressures will be higher.
Yes.
So here is where you calculate the pressures for the same volume. Whereas in pressure controlled ventilation, what will happen? You have set the pressures. The volume will decrease if the compliance worsens. So I will be just wearing because it's a complete mechanical ventilation class. So this is all you need to know about the ventilators. The trigger which initiates the inspiration,
Yes.
the total limit of the inspiration, and how do you cycle from inspiration to expiration, and then the peep. So these three are almost inspiratory ones and this is the expiratory one. And based on this, you classify the basic modes of ventilation. You want me to cover this?
Yes.
Or you all know this?
Cover this.
So I'll cover it. Yeah. So in a controlled ventilation, volume controlled ventilation is a simple thing, and you can add assist. So now all the modes that we use nowadays are assist modes. So this is a simple name for volume controlled ventilation. Controlled mandatory ventilation, another name. So breath is mandatory, and if you assist mode, always have assisted mode. So in all of this. Then the control is volume in this and pressure in this. Trigger can be time triggered in a pure controlled mode, and if you have assist modes, it can be triggered by flow or pressure. The limit is volume here and pressure here. Cycling is time or volume or flow, and time in this. And expiratory, you can set the PEEP. In the pressure support mode, the breath is spontaneous, controlled by the pressure. Triggered can be again flow or pressure. Limit is pressure in this. Cycling is flow cycling. I will be showing the flow cycling in detail, and you have an expiratory PEEP. So what all do you set is volume controlled ventilation? Anyone?
Volume.
Tidal volume and respiratory rate. And something else?
PEEP
FiO2
and
PEEP. So don't forget those things. They are also important. FiO2 PEEP. So this is all you set in a different ventilators are different things. Either you can set the total cycle time and the I ratio. Sometimes you can set the inspiratory time. And this is how all the three scalars looks like in a controlled mode. So you can be given a scalar and asked to identify the mode. So remember, try to look for square waveform. So if the flow is square waveform, this is a volume controlled mode. Okay, look for any dips in whether it is patient triggered or time triggered. Anyone?
Time
triggered. Why?
No negative deflection.
No negative deviation. Very good. What do you set in pressure controlled mode?
pressure support my pressure.
Anyone can tell me the 3-4 things?
We set the PEEP.
We set the PEEP.
Pressure support.
Then we set the rate. FiO2.
So we talk about ramp later on. Is this a controlled mode or a
Thank you.
assisted mode? Controlled mode. So this is the difference between assisted mode and a controlled mode. Okay, there will be negative deviation in the pressure. That tells you about this is the assisted mode. What all you said in pressure support mode?
Pressure support PEEP and pressure
So in some ventilators, you can also set the
PEEP and
cycling. At what percentage of the highest flow you can cycle. So normally it's at 25 to 30%, but in some ventilators you can actually set it. So this is how the graphics of a pressure support ventilation looks like. So see, this is the flow cycling. This does not reach the baseline, it's set at 25% of the highest flow. So when this is the highest flow, when it reaches 25%, there is flow cycling. This is the rise time.
how much
The respective rise time determines the amount of time it takes to reach the desired airway pressure or the peak flow rate. So it can be too fast or too slow. If the rise time is too fast, you can get an overshoot in the pressure wave, creating a pressure spike. If this occurs, you need to increase the rise time. This makes the flow valve open a bit more slowly. And if the rise time is slow, the pressure wave becomes rounded or slanted when it should be more square. It will decrease the tidal volume delivery and may not meet the patient inspiratory demands. If this occurs, you will need to decrease the rise time to open the valve faster. Then inspiratory cycle off, which I was talking about. It is known by various names in the various brands of ventilators. But this is the cycle off. These are almost 25%. Normally at 25 to 30%, sometimes you can set it very high, cycling is too soon. And if it is set too low, making the breath too long, and the patient might start to actively exhale. If the patient starts to actively exhale, you can see in the
spike.
the pressure graph, and there is an upward spike at the end of inspiration.
Yes.
So earlier we were using the SIMV modes. What were the SIMV modes? How do you identify them?
Volume and target ventilation.
And the pressure support ventilation.
Yes, sir.
So try to identify each and every graphics. Each and every set of graphics. This one set of graphics, this another set of graphics. There is a controlled mode and it's along with the pressure support ventilation. So this is a patient triggered one, flow cycled one. So you need to identify these breaths also. Same here. So if there is a PEEP, you can see the PEEP here. So you can ineffective inspiratory efforts, how you can identify that? It often appears on the flow curve as a sudden deviation of the expiratory flow towards the baseline. So it's not very clear. The flow comes towards the baseline and there is a concomitant drop in the airway pressure towards the baseline. Just small things. Ineffective inspiratory efforts occur in the lower respiratory drive or a dynamic hyperventilation. Can anyone tell me a newer modality in which you can monitor these better? So if you can identify the diaphragm contractility, you can identify the ineffective breath much more easily. Ultrasound can be one, but this can be
Transpulmonary
pressure flow, which can identify the diaphragm. I will be showing you that, the electrical activity of the diaphragm. So any deviation of inspiratory flow from the exponential declining pattern indicates a respiratory muscle effort. So in the first graph, rounded or constant inspiratory flow. Inspiratory flow is a significant inspiratory effort during insufflation and indicates an insufficient pressure support. So rounded or constant inspiratory flow. And conversely, a change in the slope of inspiratory flow towards the baseline suggests an expiratory muscle contraction during insufflation, which is caused by expiratory pressure support or prolonged mechanical ventilation. I will be showing you later on more and more graphics of this. This is a sudden one, change in the slope. Then there is early cycling occurs when flow from the ventilator ends while the patient is still making an inspiratory effort. Early cycling distorts both the flow and the pressure waveforms at the end of onset of expiration. This is the onset of expiration. Flow curve initially demonstrates a small peak expiratory flow followed by an abrupt initial reversal. So it just comes to the baseline and the expiratory flow slope has a rapid deflection towards zero, indicating the patient's inspiratory effort is prolonged. Whereas what happens in the pressure decreases rapidly from inspiratory pressure to a value below the PEEP. So this one, it comes below the PEEP with an upward convexity, indicated patient's inspiratory efforts. Then what happens in delayed cycling? When assisted breath is prolonged beyond the end of the patient's inspiratory effort. Delayed cycling is indicated distortion in both flow and the pressure waveforms at the end of insufflation. The flow curve demonstrates a change in the slope towards the baseline, indicated either an abrupt relaxation or a contraction of expiratory muscles. I will be showing a real graph in this to make it much more easier. This is how to distinguish the previous three. Then coming to esophageal curve, is measured by a balloon inflated with air positioned with the lower third of esophagus in order to estimate pleural pressure. How many of you have not seen a esophageal pressure curve? Not even seen a video?
No, sir.
You should at least see a video. Because it is a very important thing to monitor many things. Transpulmonary pressure is calculated as airway pressure minus the esophageal pressure. So it's a proxy to the pleural pressures. For that you have to position it correctly. So how do you check the position correctly? It's firstly inserted in the stomach and inflated. So it's almost like a rice tube. The stomach pressure curves show a low baseline with a small positive swing during insufflation. And gentle pressure will increase the pressure. Subsequently, the catheter is pulled out until the point where the cardiogenic oscillations appear. So initially pulled in the stomach, then withdrawn till the cardiac oscillations are there. And this is first part, and then how do you confirm the position?
Okay, sir.
So when you press gently with both the hands on the chest for a couple of seconds and release the pressure, the airway pressure and the esophageal pressure increase simultaneously and they should be equal. And the transpulmonary pressure remains stable. So that is how you identify that you are at the correct position. So firstly, position it correctly and then confirm the position. So it helps you to identify various pressures when the flow is zero. So the transalveolar pressure is often calculated using the airway pressure and the esophageal pressure at end inspiration and expiration. So end inspiration and expiration, the flows are zero and helps you to identify the pressures. So what happens at end expiration? Anyone who used it? is used to identify that we have a PEEP, whether the alveoli collapse or the PEEP is negative at end expiration. So here you can see, I don't think it's visible. Is it visible there?
Yes.
So pressure surrounding the alveoli in the middle thorax sometimes go below zero and the alveoli may collapse at the end of expiration. So you have to adjust the PEEP to have a positive pressure at end expiration, prevent atelectaoma. So in the first curve, there is some time that the pressure, the transthoracic pressures are going below zero. You have to increase the PEEP so that they remain above zero throughout the cycle and there is no atelectaoma. So this is the difference of these two. So you can find the esophageal pressures and you can subtract that from the pressures. You can use it for calculating the driving pressures also at end expiration and at the end inspiration. So end inspiratory pressures minus end expiratory pressures tell you about the driving pressures. Also you can find out about the inspiratory efforts. Whether your patient is having a strong inspiratory effort or a weak inspiratory effort. The shape of decrease in the esophageal pressure at the onset of patient inspiratory efforts provides us with this inspiration about the drive and the capacity. A strong inspiratory effort is represented by a sharp, significant decrease in the esophageal pressures. So this is a strong inspiratory effort. And this is a weak inspiratory effort. You can identify that. And by this you can actually find out the triggering also. You can correlate with the flow and pressure curves whether there is ineffective triggering or not. So it can tell you when the inspiratory effort actually starts at the level of diaphragm and can tell you about delayed triggering, ineffective inspiratory effort or a auto triggering. So some things about patient ventilator dyssynchrony. When the demands are not met throughout the respiratory cycle. I'll be showing the graphic straightforward. So trigger insynchrony occurs when the ventilator sensitivity setting is not appropriate and the ventilator does not sense the patient inspiratory efforts and fails to deliver the gas flow. So what is the problem? Sometimes there might be auto PEEP.
Yes, sir.
The presence of auto PEEP can also make triggering the ventilator more difficult. The patient has to overcome this auto PEEP and then trigger the breath. And the patient's flow demands are also not met. This is how you can identify the patient's flow demands are not met. The patient tries to inhale or exhale in the middle of the waveform or the loop, causing a dip in it. So there is scalloping. So you can address the auto PEEP by various methods. I will be asking you a question over this. So most common synchronies are ineffective efforts, double triggering, auto triggering or delayed cycling. So in ineffective triggering, what happens is the patient tries to breathe, but the ventilator does not give you a breath. In double triggering, the patient tries to breathe, but the ventilator sometimes takes it and gives double breath. In auto triggering, the patient does not try to breathe, but the ventilator gives a breath. And in delayed cycling, the patient's breath is lost. So this is an example of ineffective triggering. So by this, we are measuring the electrical activity of the diaphragm by a special probe, and we can see in this that what happens is the patient ventilated with the pressure support ventilation, there are missing efforts that can be detected from small negative deflections of the flow tracing and the positive deflection in the flow tracing. So this tells you that this patient tries to trigger, but the ventilator does not give a breath. It tries to, but it does not fully give a breath. So you can monitor it by electrical activity of the diaphragm. Then there is flow asynchrony. As you can see in the C curve, it's a patient triggered breath with inadequate flow to meet the patient's demand. The patient's demand is not met, and this is a scalloping. There is an inadequate flow. So this is a real time thing. There is a dip with the scalars, and this can also be checked in the loops. There is decreased inspiratory flow. There is a scalloping in the loops also in the inspiratory form. You can see the scalloping. Then cycle asynchrony, commonly called as termination asynchrony, occurs when the patient starts to exhale before the ventilator has completed inspiration. So can you all see this?
Yes.
So the patient's neural timing precedes the end of the mechanical ventilation and results in the pressure spike. There is a pressure spike. We had seen previously also. There is a pressure spike on the pressure waveform, and there is a rapid decline in the inspiratory flow waveform. So this is a rounding one. Inspiratory flow waveform at the end of inspiration. This tells you that the patient is trying to actively exhale. So when he makes an active effort, what happens? The pressure shoots up and the flow gradually comes to zero. Quickly comes to zero. Sorry. This is all theoretical. The patient sides the ventilator. More sedation is required, and there is higher work of breathing, longer hospital stay, and breathing cost. So just a bit about NAVA. Patient's own spontaneous breathing is required. It measures the electrical activity of the diaphragm and delivers in proportion and in synchrony with that signal. This is how a normal spontaneous breath generates. There is a pressure drop or a flow reversal which the ventilator used to initiate a ventilatory breath, but the earliest signal is usually at the level of the diaphragm. It adjusts the support level in the synchrony with the rise and fall of the electrical discharge, and they work towards a common goal to synchronize it better and to give an augmentation. A specially designed 9 electrode esophageal catheter needs to be inserted, and what it does is it amplifies the signals. So this is how the waveform looks like. This can be asked in the exam. Can you all see? This one, the electrical activity of the diaphragm is required to be measured, and NAVA level has to be set. So it synchronizes so that there is less dissynchrony and augments the tidal volume. Remember, the patient is breathing spontaneously in this. So what you have to adjust is the gain factor, what they commonly call as the gain factor of the NAVA level. And you obviously have to set backup ventilation for this. Now a few questions. What is this mode?
Control mode ventilation.
Anyone? I have not shown in the class. That's the clue.
Graphs.
Anyone?
You can at least attempt. It will be more. It will be better
Control
learning
mode
experience for all.
ventilation.
Volume control is decelerating flow. Flow is decelerating. Good.
Yes, sir.
And what can you see from this graphic?
Air trapping. Air trapping is there.
P peak is high. There is a bit of air trapping. So what are differentials?
COPD.
Differentials, not one diagnosis.
Difference.
Yeah. So what are the causes? So the problem can be So the problem is because at the machine end or at the patient end. So remember, they can be both the things. They can be king ventilator tubing, waterlogged filter, king or obstructed endotracheal tube, or in the patient end. The patient can be just biting the tube.
Maybe.
So they can all form these kind of graphics. So remember to have a differential diagnosis and to think over them. So 65-year-old presents to emergency department with shortness of breath. On examination, his BP is 144/88, heart rate is 128, respiratory is 35. His temperature is febrile. Oxygen saturation is 82% at 5 liters. He is intubated with the in view of respiratory distress, put on ventilation,
Control
and
mechanism.
patient develops hypotension after 30 minutes. Any differentials?
Anyone? Would you like to attempt? So.
You can attempt, I can see your faces. Anything else?
So air trapping is happening because of that. The pressures
Anything
are.
else? I want you to think.
The patient is getting hemodynamically unstable, so alveoli are getting distended again and again.
No, you're trying to explain me that. I want differential diagnosis. Something else.
Okay.
So don't focus just on one thing. This is a patient who's febrile. You suddenly intubate him. There's a loss of sympathetic drive. It can be relative hypovolemia. You give some drugs to intubate the patient. They can all be a cause of hypotension. Autopsy can also be there. But don't forget all those things. So again, a 55-year-old person weighing 60 kg, suffering from COPD for 20 years, a long-standing one, intubated. And he is developing definitely an autopsy. What do you want to change in these settings? These are the settings. What do you want to change? What is your aim actually? Prolong the expiratory time. How can you prolong the
RR.
expiratory time?
COPD.
You can change the I ratio.
So So we can decrease the tidal volume, we can decrease the respiratory rate
That is the
also.
last resort. You can do it definitely. 500 ml is too high. You can actually do it.
And
But
Are
when
you-
it is expected time, always see the flow graphics whether it's coming back to the baseline or not. The stretch is finishing or not, and then you can decrease the tidal volume and the respiratory rate. But whenever you do it, monitor it with a blood gas analysis. You are taking the minute ventilation. The patient can eventually learn to respiratory acidosis very easily. A 30-year-old gentleman presented to ED with complaints of respiratory distress and hypoxemia. He used to use inhalers for seasonal asthma. His breathlessness has worsened over the past 5 days, and is cyanosed. You intubate him. And what are the graphics and what are the steps to follow? Please increase resistance. So check everything. Check remove them, put an ambu,
Yes, sir.
try and ventilate the patient, and then only think about obstructive disease and give bronchodilators. This mode I have not. Any idea about this mode? Not covered this.
APRB.
APR. What do you set in this mode?
Radical mode and
P high, T high, P low, T low.
Remember, this is the spontaneous ventilation mode.
Yes, sir.
The patient can actually breathe on both the higher pressures and the lower pressures. There is the P high, P low, T high, and T low. Fine? Yeah. What is the question?